And to be honest, only Chile and the Netherlands is open to use vasodilators in shock. But if I mention even vasodilators in shock in the United States, oh yeah, then you're in trouble. But I will explain why. And it's a little bit related, of course, Mauricio fled the audience because he's afraid about this talk. I mean, the concept of this auto-regulation is very skewed by our thinking that there is only a right shift, and that in critically ill patient with chronic hypertension, there is a right shift of the curve. But what if they're on ACE inhibitors? There is no right shift when you're on an ACE inhibitor. There's a left shift if you're on an ACE inhibitor. It's a vasodilator. And so I will, let's say, show you some data and some physiological arguments why a vasodilator, even in shock and in low blood pressure shock, could have an effect, and a beneficial effect on outcome, or on perfusion. Outcome is the consequence. With this talk, there are no possible conflicts of interest. Well, as I said, if I mention vasodilators in the United States in my practice over there, that's horror. And it's biased because they think that vasodilators are counterintuitive in hypotension because you already have hypotension, you will make more hypotension. They will cause severe hypotension, not a little bit, but severe hypotension. And you need massive amount of fluids to correct the hypotension again by, let's say, restoring the mean systemic filling pressure. And you get a lot of tachycardia if you use vasodilators. Well, the idea of vasodilators is nothing new. I mean, in the Netherlands, we're very prone to it. There's only 2 studies on vasodilators. They come from the Netherlands. But the idea is old. Max Harry Weil already said in 1962 that the primary defect of shock is not pressure, but the primary defect is flow. And Starling in 1894 already said, if anything, I would rather have flow than pressure. And so a few years later, Huckabee said, well, if you have shock with lactic acidosis, given that flow is more important than pressure, then why not consider a vasodilator? Well, with this, let's say, statement that he made in 1963, nothing happened. No one dared to use a vasodilator in shock states. Well, in the Netherlands, we're very easy with this. We bolus, and I sometimes bolus a lot. 1, 2, 3, 4 milligrams of nitroglycerin to improve a microcirculatory perfusion. This is a very limited dose of nitroglycerin. Yeah, the picture is quite good. So this is the, let's say, the discoloration, the peripheral vasoconstriction that you see in some patients with shock. And as you know from the study from France, from Hamid, there's a 72 increase in odds ratio when you have discoloration like this. Well, I mean, if you don't want discoloration, add a little bit of nitroglycerin, boom, gone. This is 0.1 milligram of nitroglycerin. It doesn't change the odds ratio, to be honest. I mean, even nurses understand this. When I started in Rotterdam, and the nurses called me and said, well, the patient is in a very bad condition because he's completely blue. And then I asked, would you be more happy and more confident if the patient was completely red? And they said, yes, that would be much better. Okay, don't leave the room. You get some nitroglycerin, you push 0.1 milligram, and the patient is completely red. Immediately the nurse said, yeah, but that's just changing symptoms. You didn't do anything about the cause. Well, that's, of course, the problem. You should treat the cause and not the symptom. And the cause is not the blood pressure. There's a misunderstanding in physiology where we think that this pressure has anything to do with this pressure. And that's not true, because the regulation of organ perfusion is done by this resistor, and that's the Starling resistor. And so how does an organ increase its blood flow? Not by increasing cardiac output and not by increasing mean arterial pressure. if that was necessary to improve organ blood flow, and you do marathon, you would explode. Because if you need a 10 times increase in blood flow to your legs to run, and you need a 10 times increase in cardiac output to be able to do that, you could never exercise. And so we have, let's say, oxygen consumption regulated blood flow. And so if the oxygen consumption or the oxygen demand goes up in an organ, then this resistor opens up. And so the actual regulation of organ perfusion is vasodilation and not vasoconstriction and not manipulating blood pressure. We hardly increase our blood pressure if we increase our cardiac output to 25 liters when we do exercise. And that's good, otherwise our brain would explode and we would go into, let's say, immediate organ donor if you do exercise. You would have brain herniation. And so that's not the case. And so when you then go to a physiological model of what is the effect of vasodilation, then you get a completely different picture. If you look at the effect of vasoconstriction, so you bleed someone out, and that's why you see these discolorations, well, usually the blood pressure increases. In acute bleeding, blood pressure increases. But despite the increase in blood pressure, you get these blue and cold patients. Why? Because the arteriolar constriction, so the constriction of the Starling resistor limits blood flow. And so you completely shut down the blood flow to your skin and to your muscles. And that's why you turn blue. And so the increase in blood pressure has no effect on improving microcirculation. Now, if you go to a hypotensive state due to vasodilation, you actually get an increase in this microcirculatory pressure because your Starling resistor opens up. And so although you have a very significant, or may have, a very significant decrease in your mean arterial pressure, you have a significant improvement in your precapillary pressure. And that's why if you give a little bit of nitroglycerin to these patients, the blood pressure may drop, but they immediately turn completely red. Unless they have diffuse intravascular coagulation, then nothing happens. But if it's vasoconstriction, it's resolved within minutes. But, I mean, in some patients, we still have this vasodilatory state, and still we have abnormal microcirculation, as, for instance, in septic shock, and that could be related to the increase in venous pressure. And that's why in the previous session where we talked about is central venous pressure dead? No, absolutely not, because if you increase your central venous pressure, then your post-capillary pressure will increase. And especially the kidney is extremely sensitive to only very small increases in central venous pressure. Our group just did a study in cardiogenic shock, looking at new acute kidney injury and cardiac failure. The difference in CVP between the two groups that developed and did not develop cardiac failure was 3 centimeters of water of CVP. It was the only significant predictor of new kidney failure. That's 3 centimeters of water. That's a very limited increase in central venous pressure. And so that's a problem. If you fluid resuscitate to increase your CVP, you're causing a problem. You're not solving anything, you're causing also something. Your cardiac output may increase, but if your CVP increases, you're in trouble. And that's what the group of Didier Payen showed, where they retrospectively looked at the effect of CVP on new kidney injury, and they found that in the surviving sepsis guideline, let's say, CVP numbers, 8 to 12, there was a huge increase in new kidney injury. So by increasing CVP with fluid resuscitation, you're increasing the risk of acute kidney injury. Why? Because your microcirculation goes down. This is what Namke Vellinga in Leeuwarden showed. She looked at the effect of CVP on microcirculatory perfusion and found that if your CVP is higher than 12, then your microcirculatory perfusion under your tongue is significantly lower than when you have a low CVP, less than 12. And that's an explanation why you can have, let's say, acute kidney injury with what some think is a very limited CVP of 12. We looked at the effect of nitroglycerin on organ perfusion, and this is one of the early studies that Jasper van Bommel did, because we had a lot of discussions with the surgeons in gastric tube reconstructions, and they wanted the blood pressure to go up and wanted to give enormous amounts of fluids to have high blood pressures. As you understand, surgeons have no clue about the relation between cardiac output and blood pressure, and they think that fluids are like inotropes and vasopressors. And so they asked us to give a lot of fluid, and we said that doesn't make sense. If you increase central venous pressure, you harm the gastric tube, and you don't do any benefit. Yeah, but they said in the OR we saw that if the blood pressure was higher, the gastric tube was much better perfused. And we said, okay, what we usually say, let's kill a few pigs and find out. And so we killed a few pigs, and one of the junior surgeons did gastric tube reconstruction in a pig. And we varied the blood pressure between a very low, I mean, there's no discussion, a mean of 50 is very low, and this is incredibly high, 110. And as you can appreciate, if you look at the gastric tube, and this is in the fundus, but we looked at every level, of course, of the gastric tube, there's no effect. Increasing blood pressure does not improve microcirculatory perfusion, period. But if you add nitroglycerin, then at every level of blood pressure, even the very low blood pressure, the perfusion was always better. At a very low level, but also at a high level. Why? Well, the only significant difference we found between the two groups is the lower central venous pressure. And remember, this is, as I told you, in the cardiac patients we found 3, and here it's about 3. There's a difference of about 3 in central venous pressure, 2 to 3. It's a very limited difference, but the huge effect of this very limited difference in central venous pressure on microcirculatory perfusion in every level of the gastric tube. Now, this is the landmark study of Peter Spronk when he was in Amsterdam. In Amsterdam, they were very keen on giving a lot of nitroglycerin and other vasodilators, and so they studied the effect of nitroglycerin on microcirculatory perfusion under the tongue, and they showed that if you give nitroglycerin, that the microcirculation improves. Whether you look at the microvascular flow index or in the small capillaries or in the larger capillaries, it didn't make any difference. There was an improvement overall in the microcirculation. Too bad he didn't do an on-off study to see whether the effect disappeared if you stopped the nitroglycerin, but this was, let's say, the initiation of the use of nitroglycerin, at least in the Netherlands. We implemented mandatory the use of a vasodilator in shock patients when they didn't decrease their lactate levels. And so in this study that we published in the Blue Journal, we said your lactate levels should decrease every 2 hours by 20%. If not, and you have corrected the hypovolemia, you have an adequate blood pressure, you have to add a vasodilator, in this case nitroglycerin. And as you can see, what we think about fluids, that's not true. We used a little bit more fluids, half a liter, in the protocol hours, 0 to 8 hours. But then again, after we stopped the resuscitation mandated by protocol, we used less fluid. So overall, in the nitroglycerin group, we didn't use more fluids. And we didn't have hypotension. And we didn't have tachycardia. And this is a mixed group. It's not septic shock, it's a mixed group of patients with circulatory failure and an increased lactate level. That was the entry criteria. And as you can see, at T0, at T8 is the end of the study, patients that received nitroglycerin or did not receive nitroglycerin, there was no difference in blood pressure, there was no difference in heart rate, and there was no difference in the amount of norepinephrine, because you could argue, well, in the nitroglycerin, there was a decrease in blood pressure, and so they gave more norepinephrine to correct the blood pressure. That's not true. So even in this mixed group, the use of nitroglycerin was safe, and the protocol was associated with a 20% improvement in mortality. And Kostya de Naal, one of our PhD and our staff members, did a study in cardiogenic shock and showed a very nice dose-dependent effect of the microcirculation of norepinephrine not related to the changes in cardiac output. As you can see in this one, The blue patients improved their cardiac output, and the red one did not improve their cardiac output. The effect of nitroglycerin is independent of the change in cardiac output and independent in the change of blood pressure. Because in these patients, as you know, cardiologists are keen to keep their patient dry in cardiogenic shock. And so the addition of nitroglycerin had a significant effect on blood pressure. There was a significant drop, but an improvement in microcirculation. Why? Because there was a huge drop in central venous pressure from around, let's say, 11 to around 5. And so despite the hypotension, there was a significant improvement in microcirculation, probably related to central venous pressure. Now, Alessandra Lima, one of our postdocs, did a study and did an on-off study. So we looked at peripheral circulation, like the discoloration or just being cold, and he titrated nitroglycerin to normalize up to 8 milligrams, 16 milligrams per hour. And as you can appreciate, all the measures that we used for abnormal peripheral perfusion, all these were abnormal at baseline. That was the entry criteria. They all corrected with the addition of nitroglycerin, and they all returned to abnormal once the nitroglycerin was stopped. And so, yeah, adding a vasodilator improves your microcirculation, not only under the tongue, but also your peripheral microcirculation. Should you then add a nitro donor or nitroglycerin to every patient? No, that doesn't make sense. Don't do these crazy studies where we add anything to every patient. That doesn't make sense. Add something to a patient that needs a drug or an intervention. And so that's what this study from Christian Boerma showed. If you add nitroglycerin to everyone, also patients that don't need it, that's not very beneficial. There was an almost significant increase in mortality in the nitroglycerin group. So that doesn't make sense. Give nitroglycerin or a vasodilator to someone who needs it. So in conclusion, circulatory failure is associated with peripheral vasoconstriction. You can easily see it or feel it. Vasodilation increases microcirculatory perfusion pressure despite an even decrease, a possible decrease in mean arterial pressure. And vasodilators decrease the central venous pressure that may be, let's say, responsible for this improvement in microcirculatory perfusion pressure. And nitroglycerin improves both the microcirculation, as you visualize under the tongue, and the peripheral circulation that you can easily feel or measure at the skin of the patient. And I think the use of nitroglycerin is safe. It should not be used as a standard therapy. Whether it improves outcome, I don't know. We have 0 studies. Thank you very much.